isn't interposed in front of the liver/gallbladder. If a multiple-choice writer wanted to be sneaky, she could tell you the patient has Caladity Syndrome, which just means that have bowel in front of their liver. Some sources will list this as a contraindication to PC. Even if the procedure instantly resolves all symptoms, you need to leave the tube in for 2 to 6 weeks until the tract matures, otherwise you are going to get a bile leak. After that at least 2-week period you should perform a cholangiogram to confirm that the cystic duct is patent before you pull the tube. Most places will clamp the tube for 48 hours prior to removal. This helps confirm satisfactory internal drainage. Managing bile leak is bad, it can cause massive biliary ascites and chemical peritonitis. You can place a tube within the bile ducts to divert bile from the location of the leak, this usually works. 494. General biopsy pearls. There are 2 primary techniques for sampling tissue. I. Fine needle aspiration, cytology. 2. Cutting needle core biopsy. Fine needle aspiration, this is for situations when you only need a few cells. It is typically performed through a 21 or 220 Chiba needle. Vacuum aspiration with a 20 cm³ syringe is applied as you pass the needle back and forth through the target. Trivia, apply gentle suction as you remove the needle. If you suck too hard, a tiny sample could get lost in the syringe. If you forget to apply suction, the sample will stay in the patient. The needle is small, so the risks are small. Cutting I-core needle, this is for situations when you need a larger sample. Sample. There are lots of devices, but the most basic mechanism involves a needle with 2 parts, an outer shaft for cutting, and an inner stylet. Trivia, for the purpose of multiple choice, the target is cut where the outer shaft is advanced. Outer sty/ET, inner sty/ET. Outer sty/ET closes to cut sample. Trivia, the general rule is pick the shortest length needle that will reach the target. Trivia, automated systems fire both the inner and outer components to take the sample. The key point is that with these systems the sample is taken from tissue 10 to 20 mm in front of the needle. 495. Liver biopsy. You can do liver biopsy. You can do targeted approaches for a specific lesion, or you can do non-targeted approaches. Sampling. General pearls include trying to cross the capsule only once, biopsy of subcapsular masses through an area of uninvolved liver, and avoiding the diaphragm. If given the choice, you want to biopsy peripheral lesions through 2 to 3 cm of normal liver prior to hitting the target. This is done to avoid a bloodbath. There is ascites. Next step equals drain it prior to doing the biopsy. This path might be okay if it's thick. 2 cm would be. Trivia, mild shoulder pain, referred pain, is common after liver biopsy. This direct path into the lesion will bleed like stink. 2 cm would be ideal. This path might be okay if it's thick enough. Trivia, prolonged shoulder pain, 5 minutes, equals possible bleed care sign. Next step equals re-evaluation with ultrasound. Always look behind the liver, Morrison's pouch, to see if blood is accumulating. Bleeding after liver biopsy occurs more from biopsy of malignant lesions, compared to diffuse disease. Contraindications, uncorrectable coagulopathy, thrombocytopenia, 50,000 infections in the right upper quadrant, are contraindications for a conventional biopsy. Trivia, biopsy of carcinoid mets is controversial and death by carcinoid crisis has occurred after biopsy. Massive ascites or severe coagulopathy. Next step equals transjugular approach. 496. Transjugular liver biopsy. The rationale is that the liver capsule is never punctured, so bleeding is less of a risk. Obviously this is a non-targeted biopsy for the diagnosis of infectious, metabolic, and sometimes neoplastic processes. Classic example equals grading chronic Hep C. Procedural trivia. Specific Licati 01 is severe coagulopathy, massive ascites, failure of prior percutaneous liver biopsy, massive obesity, fat even by West Virginia Slandards, patients on mechanical ventilation, need for additive vascular procedures like TIPS. The general technique is to access the hepatic veins via the IVC, via the right jugular vein. Most people will tell you to biopsy through the right hepatic vein while angling the sheath anterior. The reason this is done is to get the biggest bite of tissue and avoid capsular perforation, which was the entire point of this pain in the AS procedure. Trivia, never perform an anterior biopsy from the middle hepatic vein. Trivia, this procedure has the added benefit of allowing you to measure hepatic venous pressures, which can guide therapy or assess Varicoceles bleeding risk. 497. Hepatic splenic trauma. Embolization is a potential method for dealing with significant trauma to the hepatic or splenic arteries. Opinions on the exact role angiography vary from institutions, so read my mind questions are likely. I think the most likely type of indication question might actually be who does not go to angio. The most accepted contraindication in a bleeding patient is probably a very busted up unstable dude who needs to go straight to the OR for emergent laparotomy. Tools and strategy. Hepatic considerations. Indications * agreed upon by most. Continuous hemorrhage, active extrav, in a patient who is borderline stable post-resuscitation. Early ongoing liling after a surgical attempt to gain primary hemostasis. Rebleeding alter successful initial embolization. Post-traumatic pseudoaneurysm and AVFs, even if they aren't currently bleeding. Gel foam pledgets particles and / or microcoils are typically used. Massive non-selective hepatic artery embolization is usually avoided to reduce the risk of large volume tissue necrosis. What's the main issue with tissue necrosis? Hepatic abscess development, which is fairly common in a major liver injury anyway. Trivia, arterial pseudoaneurysms should not be placed in the aneurysm sac. This can lead to a late rupture. The strategy is to occlude the distal and proximal parent vessels. You'll want to perform completion angiography to prove the thing is occluded prior to catheter removal. Sandwich technique to exclude arterial pseudoaneurysm. Distal end first. Then pull back. Hepatic surface is bleeding from more than one spot. Next step equals gel foam or particles. Hepatic pseudoaneurysms can be treated at the site of injury with the sandwich technique because they are not end arteries. Plus the liver has a dual blood supply. 498. Tools and strategy continued. Spleen considerations. Splenic laceration, without active extravasation, is not considered an indication to angio by most people. Remember to use your mind-reading powers to confirm the question writer agrees. The spleen does not have a dual blood supply, and is not considered an end organ like the liver. So if you go nuts embolizing it, you can infarct the whole fucking thing. Focal splenic abnormality. Next step equals selective embolization treatment. Multiple bleeding sites. Next step equals use a proximal embolization strategy, and drop an Amplotza plug into the splenic artery proximal to the short gastric arteries. The idea is to maintain perfusion but reduce the pressure to the spleen. Slower blood will clot, with the benefit of preserved collateral supply and less infarction risk. Short. Trivia: even with this proximal embolization strategy, the patient usually does not require vaccination post-embolization, as a lot of functional tissue should remain. 499. Hcc treatment. You will read in some sources that transplant is the only way to cure an HCC. Others will say transplant, resection, or ablation are curative if tumor is small enough. Arterial embolization, TACE, is typically used in situations where the tumor burden is advanced and the patient cannot undergo surgery. ACR appropriate, liver transplant. Transplantation should be considered only in patients 65 years of age with limited tumor burden, tumor 5 cm or up to 3 tumors 3 cm. Transarterial chemoembolization, TACE, most people will consider this first line for palliative therapy in advanced cases. The mechanism relies on HCC's preference for arterial blood. High concentration of chemotherapy within lipiodol, iodized oil transport agent, is directly delivered into the hepatic arterial system. The tumor will preferentially take up the oil, resulting in a prolonged targeted chemotherapy. The lipiodol is usually followed up with particle embolization, with the goal of slowing down the washout of the agent. Absolute contraindication equals decompensated, acute on chronic, liver failure. Trivia: some sources will list portal vein thrombosis as a contraindication because of the risk of liver infarct. Others say portal vein thrombosis is fine as long as an adjustment is made to limit the degree of embolization, and you can document sufficient hepatic collateral flow. Simply read the mind of the question writer to know which camp they are in. Trivia equals TACE in patients with a biliary stent, prior sphincterotomy, or post-Whipple are all high risk for biliary abscess. Trivia equals sterile cholecystitis or chemical cholecystitis are buzzwords that when used in the setting of TACE should lead you to believe that the agent was injected into the right hepatic artery prior to the takeoff of the cystic artery to the gallbladder. Trivia equals TACE WI11 prolonged survival better than systemic chemo. Trivia: unfortunately repeat TACEs can result in a ton of angio time and therefore a ton of radiation. Patient do sometimes get skins burns, usually on their left back because of the RAW camera angle. RFA: tumor is destroyed by heating the tissue to 60 degrees center. Any focal or nodular peripheral enhancement in the ablation lesion should be considered residual recurrent disease. Sometimes on the immediate post-treatment study you can have some reactive peripheral hyperemia, but this should decrease on residual studies. Important trivia is that RF ablation is indicated in patients with HCC and colorectal mets who can't get surgery. TACE and RFA: as a point of trivia, it has been shown that TACE and RFA for HCC lesions larger than 3 cm will improve survival more so than either treatment alone. This is still not curative. 500. Yttrium, 90 radioembolization, and alternative to TACE is using radioactive embolic materials, Y90. The primary testable trivia regarding Y90 therapy is understanding the pre-therapy workup. There are basically two things to know. 1. Lung shunt fraction: you give TC 99 Ma to the hepatic artery to determine how much pulmonary shunting occurs. A shunt fraction that would give 30 GY in a single treatment is too much. Y90 is contraindicated. What is this yttrium? Yttrium-90 is a high-energy beta emitter with a mean energy of 0.93 MeV. It has no primary gamma emission. Yttrium-90 has a half-life of 64 hours. After administration, 94% of the radiation is delivered over 11 days for half-lives. The maximum range of irradiation from each bead is 1.1 centimeters. 2. The take-off of the right gastric. The fear is that you get non-targeted poisoning of the stomach, leading to a non-healing gastric ulcer. To help prevent reflux of the Y90 poison into places you don't want, basically anywhere that's not liver, prophylactic embolization of the right gastric and the GDA is performed. The right gastric origin is highly variable and can come off the proper hepatic or the left hepatic. Trivia review. Shunt fracture 30 GY to the lungs equals no Y90. Before you give the poison, embo the right gastric, which has a variable takeoff and GDA, so you don't put a hole in the stomach. If you inject the Y90 here, you can imagine it refluxing in the right gastric or GOA. 501. Generalized tumor treatment trivia, regardless of the organ. RFA. Cure equals 4 centimeters. Tumors need to be less than 4 centimeters or you can't cure them. You can still do RFA on tumors bigger than 4 centimeters, but the buzzword you want for this is debulking. Debulk equals 4 centimeters. You always need a burn margin of 0.5 to 1.0 centimeters around the tumor. So your target is the tumor and another LCM of healthy organ. A key structure, something you don't want to burn up, that is within 1 centimeter of the lesion, is considered by most to be a contraindication to RFA. Some people won't cook lesions near the vascular hilum or near the gallbladder. Be on the lookout for bowel. It is possible to cook bowel adjacent to a superficial lesion. If they are asking you if a lesion is appropriate for RFA and it's superficial, look for adjacent bowel. That is probably the trick. RFA requires the application of a grounding pad on the patient's leg. Blankets should be jammed between the arms/body and between legs to prevent closed-circuit arcs/bums. Hot withdrawal supposedly can reduce the risk of tumor seeding. Basically, you leave the cooker on as you remove the probe to burn the tract. Heatsink, this is a phenomenon described exclusively with RFA. Lesions that are near blood vessels 3 mm or larger may be difficult to treat, without getting fancy, because the moving blood removes heat away from the lesion. You can overcook the turkey. Temperatures at I00C or greater tend to carbonize the tissue near the probe, reducing electrical conductance, resulting in suboptimal treatment. Around 60 C is the usual target. Post-Embolization Syndrome, just like a tumor embolization, you can get a low-grade fever and body aches. The larger the tumor, the more likely the syndrome, just like embolization. Low-grade fever and body aches post-ablation. Next step equals supportive care. Persistent fever x 2 to 3 weeks post-ablation. Next step equals infection workup. 502. Cryoablation treatment response post-therapy study is typically performed at 3 months, with additional follow-ups at 6 months and 12 months. A good result should be lower in density relative to the adjacent kidney. On MR, a good result is typically T2 dark and TL ISO or hyper. Size, just like RFA, ablated lesions can initially appear that they grew in size relative to the pre-treatment study. With time they should progressively shrink, usually faster than with RFA. An increase in size, after the baseline post-treatment, should be considered recurrent tumor. Enhancement, any nodular enhancement, 1 OU change from pre-contrast run, after treatment should be considered cancer. Vocab, residual tumor, or incomplete treatment, equals vocab words used when you see focal enhancement in the tumor ablation zone of a patient for their first post-therapy study. Recurrent tumor, equals word used when you see focal enhancement in the tumor ablation zone that is new from the first post-therapy study. 505. SEC110N 11 luminal GI. G-tubes. A G-tube is a gastric tube placed directly into the stomach. They are primarily used to prolong the suffering of stroked-out Alzheimer patients with stage 4 sacral decubitus ulcers. Traditional method, radiographically inserted gastrostomy, rig. The basic idea is that you put an NG tube down and pump air into the stomach until it smushes flat against the anterior abdominal wall. Then you spear it and secure it with 4 T-tacks to retract the stomach to the abdominal wall in the gastric body. Then spear it again, wire in and dilate up to the size you want. Typically, the T-tacks are removed in 3 to 6 weeks. Other things that you can do is give a cup of barium the night before to outline the colon. If the patient has ascites, next step equals drain that first. The ideal target. Left of midline, lateral to the rectus muscle to avoid inferior epigastric. Mid to distal body. Equal distance from the greater and less curves to avoid arteries. Anatomy trivia, the cardia of the stomach is actually the most posterior portion. There is another method often called a PJG because of the perioral route. In that version you stab the stomach and tread a wire up the esophagus. Then you grab the wire, slip the tube over it, and advance the tube over the wire into the stomach, all the way out the stabbed hole. Then it's back to the nursing home for grandma. Honestly, it's probably best to do it with a scope, but since we are radiologists, my official statement is that only a radiologist can do this procedure well. 506. Esophageal stents. Probably the most common indication for one of these is esophageal cancer palliation. These are usually placed by GI, but that doesn't mean you won't get asked about them. In the real world, most people don't even size these things. The overwhelming majority of lesions can be covered by 1 stent. Having said that, for the purpose of multiple choice you need a stent with a length at least 2 centimeters longer than the lesion on each side. You do the procedure through the mouth. Imaging it would be great fun to try and place a stent through the nose, if you really hated the person. You give them contrast, some oral contrast to outline the lesion. An Amplot's wire is dropped down into the stomach. The stent, usually self-expanding, is deployed over the wire. Post-Angioplasty. Most people don't angioplasty after deployment of the stent. However, if the tumor is bulky and near the carina, some sources will suggest doing a pre-stent angioplasty test up to 20 mm to see if this invokes coughing eye stridor. The concern is that a large tumor may get displaced against the carina and cause a respiratory emergency. If the patient doesn't cough from the test, you are safe to deploy the stent, probably. Upper 113 cancer. Most esophageal cancers are in the lower 1/3. If the question specifically tells you it's higher up, or shows you, they may be leading you towards a "don't cover the larynx dumbass" question. The way to avoid this is to have endoscopy do the case, so they can identify the cords. If that isn't an option, then placing a smaller device might be an alternative. STE11T drops into the stomach, most people will just leave the motherfucker alone. However, if the patient is symptomatic, endoscopic removal is the textbook answer. STE11T occludes. Occludes. Next step equals esophagram. The most common cause is food impaction, which sometimes can be cleared with a soda. If that fails, the next step is endoscopy. If it's not food but instead tumor overgrowth, sometimes you can place a second stent. It depends on a lot of factors, and asking that would be horse shit. Gamesmanship. Acute obstruction is likely food. Worsening symptoms over time is likely tumor. 507. GI bleed. You can split GI bleeds into two categories: upper, proximal to ligament of Treitz, and lower. Upper GI. Some testable trivia is that 85% of upper GI bleeds are from the left gastric, and often if a source cannot be identified, the left gastric is taken down prophylactically. If the source of bleeding is from a duodenal ulcer, embolization of the GDA is often performed. About 10% of the time, an upper GI bleed can have bright red blood per rectum. Pseudovane sign. This is a sign of active GI bleeding, with the appearance of a vein created by contrast pooling in a gastric rugae or mucosal intestinal fold. If you aren't sure if it's an actual vein, the pseudovane will persist beyond the venous phase of injection. Delafoy's lesion. This is a monster artery in the submucosa of the stomach which pulsates until it causes a teeny tiny tear, not a primary ulcer. These tears can bleed like stink. It's typically found in the lesser curvature. It's not exactly an AVM, more like angiodysplasia. Sometimes you can treat it with clips via endoscopy. Sometimes it needs endovascular embolization. When J.pancreatic arcade bleeding 11E11 RYSM, you say celiac artery. Tenosis. There is a known association with celiac artery compression, median arcuacy ligament, and the dilation of pancreatic duodenal arcades with pseudoaneurysm formation. Gamesmanship. It is classically shown with an angiographic run through the SMA, showing a dilated collateral system and retrograde filling of the hepatic artery. Retrograde filling of the hepatic artery should make you think about celiac stenosis or occlusion. Injection in SMA fills a dilated pancreatic duodenal collateral system. 508. Upper GI bleed. Next step algorithm. Treat with posit/endoscopy failed or noticeable. Upper GI bleed endoscopy angio. 3 Pafuli negative phase CTA targeted, non-target if needed. Lower GI. The workup for lower GI bleeds is different than upper GI bleeds. With the usual caveat that algorithms vary wildly from center to center, this is a general way to try and answer next step type questions regarding the workup. Conservative stable. Lower GI bleed/endoscopy, H5P/E. (190) Angio. Causes Whitlow angiography buzzwords. Angiodysplasia, right-sided finding. Early draining vein. Embolization of angiodysplasia rarely stops a rebleed, and these often need surgery. Diverticulosis, left-sided finding, usually. More commonly venous. LF arterial, filling the diverticulum first is classic. Meckel's, usually shown on Meckel's scan. The feeding artery, vitellin, has a classic look with extension beyond the mesenteric border, no side branches, and a corkscrew appearance of the terminal portion. Technical aspects trivia. You will want to runs of all three vessels, SMA, celiac, IMA. Some old school guys will say to start with the IMA because contrast in the bladder will obscure that territory as the procedure continues. That's not really an issue anymore with modem DSA, and starting with the SMA will typically be the highest yield. You have to sub-select each vessel. Runs in the aorta are not good enough, and that would never be the right answer. Oleat if you don't see bleeding. You can try provocative angiography, which is not nearly as interesting as it sounds. This basically involves squirting some vasodilator, nitro I00-200 mcg, or thrombolytic drug, TPA 4 mg, into the suspected artery to see if you can make it bleed for you. Oleat if you do see it bleeding. Bleeding? Administer some street justice. Justice. Anyone who trained in the last 30 years is going to prefer microcoils and PVA particles. Old guys might use gel foam. Alcohol should not be used for lower GI bleeds, causes bowel necrosis. Microcoils, good because you can see them. Good because you can place them precisely. Bad because they deploy right where you drop them. So you need to write up next to that bleed to avoid a large bowel infarct. Trivia equals inability to advance the microcatheter peripherally is the most common cause of microcoil embo failure. I say non-selective embolization of bowel with microcoils, you say bowel infarct. PVA, good because they are flow directed. So you don't need to be as peripheral compared to the microcoils. Bad because you have less control. Trivia, P articles must be 300 to 500 microns. Particles that are smaller will / could cause bowel infarct. 510. But Prometheus, my 97-year-old attending, says you should use vasopressin. Between me and you, this argument was settled in 1986 by a guy named Gomez. The dude showed coils stop GI bleeds 86% of the time, compared to 52% for vasopressin, and the shit we have today is way better, making the disparity even greater. Having said that, some dinosaurs still do it. For the purpose of multiple choice, this is what one would know. Vasopressin works as a vasoconstrictor. Vasopressin does not require superselection. You can put it right into the main trunk of the artery. Vasopressin sucks because the rebleed rates are high once the drug wears off. Vasopressin can actually cause non-occlusive mesenteric ischemia, NOMI. Vasopressin should not be used with large artery bleeding, i.e. splenic pseudoaneurysm, bleeding at sites with dual blood supply. Classic example is pylorotoadenal bleed, severe coronary artery disease, severe hypertension, dysrhythmias, and after an embolotherapy treatment, risk of bowel infarct. Post-embolization, you need to do angiography post-embolization to look for collateral flow, if there is a dual supply. The classic example is, after performing an embolization of the GOA for duodenal ulcer, you need to do a run of the SMA to look at the inferior pancreaticoduodenal. You might have to take that one out too, but obviously that would increase the risk of bowel infarct. Trivia, risk of bowel infarct is way lower for upper GL bleeds, because of the extensive collateral supply, relative to bleeds distal to the ligament of Triets. 511. Section 12, abscess drainage. General tactics. In general, there are two methods. You can use a trocar, or you can use the Seldinger technique, wire-guided. Trocar, you nail it with a spinal needle first. Then adjacent to the needle, in tandem, you place a catheter. Seldinger, one stick with a needle, then wire in, dilate up and place a catheter. Drain size, the grosser and thicker stuff will need a bigger tube. If forced to guess, I'd go with 6 to 8 F for clear fluid, 8 to 10 F for thin pus, 10 to 12 F for thick pus, 12 F and for collections with debris, or in collections that smell like a zombie farted. Drain type, you pretty much always use a pigtail. I wouldn't guess anything else. Trivia, I gamesmanship. Any next step question that offers to turn Doppler on prior to sticking it with a needle is always the right answer. Trying to trick you into core needling a pseudoaneurysm is the oldest trick in the book. Decompressing the urinary bladder prior to a pelvic abscess drainage is often a good idea. Collection has pus. Next step equals aspirate all of it as much as possible. Prior to leaving the drain, you can't advance into the cavity because it's too fibrous / thick-walled. Next step. I'd try a hydrophilic coated family medicine. Want you to put a 3-way on that 12F drain. Next step equals don't do that. You are reducing the functional lumen to 6F. 512. Trivia, I gamesmanship continued. Family medicine wants you to hold off on antibiotics till after you drain this unstable septic shock patient's abscess. Next step equals don't do that. Antimicrobial therapy should never be withheld because some knucklehead is worried about sterilizing cultures. 1. Cultures almost never change management from the coverage they were on anyway. 2. The trauma of doing the drainage will seed the bloodstream with bacteria and make the sepsis worse. Family medicine wants to know how many cc to flush this complex but small abscess with. Remember that flushing and irrigation are different. Flushing is done to keep the tube from clogging with viscous poop. Irrigation is when you are washing out the cavity. The solution to pollution is dilution for complete cavity drainage. Going nuts with the irrigation can actually cause a bacteremia. The vignette could say something like waxing a waning fever corresponding to flush schedule. The next step would be to train the nurses of family medicine to limit the volume to less than the size of the cavity. You irrigate the abscess with 20 centimeters cubed of fluid, but when you aspirate back you only get SECS. Next step. Stop irrigating it. You have a big problem. The fluid, which is dirty, is being washed into a location that is not able to be sucked back out by the tube. So you are creating a new pocket of infection that isn't being drained. Catheter started out draining but now is stopped. Next step equals 1. Confirm that it is in the correct location and not kinked, might need imaging if not obvious at bedside. Then 2. Try flushing it or clearing an obstruction with a guide wire. If the catheter is clogged for real, then you'll need to exchange it, probably for a larger size. If the tract is mature, older than a week, you can probably get a hydrophilic guide wire through the tract into the collection to do an easy exchange. Remove the catheter when 1. Drainage is less than 10 centimeters cubed a day, 2. The collection is resolved by imaging, CT, ultrasound, etc., and 3. There is no fistula. Persistent fever 48 hours post-drainage. The patient should get better pretty quickly after you drain the abscess. If they aren't getting better, it implies one of two things: 1. You did a shitty job draining it, or 2. They have another abscess somewhere else. Either way, they need more imaging and probably another drain. The drainage amount spikes. This is a bad sign. In a normal situation, the drainage should slow or taper to nothing, and then once you confirm the abscess has resolved, you pull the drain. Spikes in volume, especially on multiple choice exams, suggest the formation of a fistula. Next step is going to be more imaging, possible with fluoro, to demonstrate the fistula, urine, bowel, pancreatic duct, bile duct, etc. 513. Pelvic abscess drainage, tubovarian abscess, diverticular abscess, or periappendiceal. General ideas for choosing the correct route. 1. All things equal, pick the shortest route. 2. Avoid bowel, solid organs, blood vessels, inferior epigastrics are classic, nerves. 3. Try not to contaminate sterile areas. 4. Choose the most dependent position possible, usually posterior or lateral, to facilitate drainage. Routes. Most abscesses in the pelvis are layering in a dependent position, so anterior routes are typically not easy. In general, there are 4 routes: transabdominal, transgluteal, transvaginal, and transrectal. I'm gonna try and cover the pros/cons and testable trivia for each route. Transabdominal, the pull of gravity tends to cause infection to layer in the more posterior spaces. As a result, transabdominal approaches tend to be long, and therefore violate one of the 4 general ideas. If you are shown an abscess where this would be the best, shortest route, then remember to watch out for the inferior epigastrics. For sure, there will be an option to stick the trocar right through one of them. Make sure you ID them before you choose your answer. Transgluteal, the transgluteal approach is done for a variety of posterior targets. The patient is positioned prone for targeting. Avoid the sciatic nerve and gluteal arteries by access through the sacrospinous ligament. Ligament. Medial as possible. Inferior to the piriformis. Disadvantages: legit risk of artery/nerve injury. Prone to catheter kinking. Gotta use CT, radiation. ////// PCJ / OO. Transgluteal. Endoluminal routes. There is a subset of perverts who prefer to biopsy and drain things through the vagina, tuna purse, and / or the rectum. Not that there's anything wrong with that. Well, actually, the primary disadvantage of both of these endoluminal routes is catheter stability. Many catheters are literally pooped out within 3 to 4 days. Although advocates for these routes will argue that A, they are more fun to do, and B, most collections resolve within 3 days. Transvaginal, biopsy and / or drainage through the vagina, pink taco, has the advantages of providing a very short, safe route that can be guided by transvaginal ultrasound, allowing for no radiation and very accurate placement. This was the classic in-office route for drainage of infected gynecologic fluid collections, PID related. The procedure is done in a lithotomy position. Catheter size is traditionally limited up to 1/2F. You should never do this to a patient under the age of 14, not even Jared from Subway would try that. Although controversial, it is possible, and well described in the literature, to drain a biopsy adnexus cysts through the vagina, twinkle cave. Vaginal prep by cleansing prior to the procedure is controversial and unlikely to be tested. Transrectal, of the 3 routes, gluteal, vaginal, rectal, transrectal is supposedly the least painful, although in my literature review the psychological pain was not discussed. This K-Jane thing would really fuck with my machismo. Essentially, this route offers all the advantages of the transvaginal route, ultrasound guidance, very short safe route, plus the added advantage of presacral access. Depending on what you read, people will argue this is first line, over transgluteal, from presacral coagulation, but that is highly variable. Choosing between transgluteal and transrectal for a presacral collection would be the worst read my mind question ever. If forced into that scenario, I would set aside the psychologic trauma to the alpha male ego and use 1. The size of the collection. Do you think that will drain before he/she poops the catheter out? And 2. Is the transgluteal route safe? Are the vessels nerves obviously in the way? Prep with a cleansing enema is not controversial and endorsed pretty much everywhere. Presacral collect ion collection. IL4L for rectovesical pouch. RL5. Liver abscess. Lots of etiologies for these, but don't forget to think about the appendix or diverticulitis. The draining of these things is somewhat controversial, with some authors feeling the risk of peritoneal spread outweighs the benefits and reserving the drainage for patients with a poor prognosis. Other authors say that everyone and their brother should get one and consider it first-line treatment. A pearl to draining these things is to not cross the pleura. You'll give the dude an empyema. If there is a biliary fistula, prolonged drainage will usually fix it. Biliary drainage or surgery is rarely needed. Trivia: biopsy aspiration of echinococcal cysts can cause anaphylaxis. Surgical removal of the presumed echinococcal cysts should be discussed with surgery before attempting the procedure in IR. You want to be able to blame it on them if shit goes bad. Renal abscess. Renal abscess is usually secondary to ascending infection or hematogenous spread. The term paranephric abscess is used when they perforate into the retroperitoneal space. When they are small, 3 to 5 centimeters, they will resolve on their own with the help of 4 antibiotics. Indications for aspiration or drainage include a large, 3 to 5 centimeters, symptomatic focal fluid collection that does not respond to antibiotic therapy alone. The strategy is to use ultrasound and stick a pigtail catheter in the thing. After a few days, if the thing is not completely drained, you can address that by upsizing the tube. If you create or notice a urine leak, you'll need to place a PCN. There is really only relative contraindication, bleeding risk, etc., and the procedure is generally well tolerated with a low complication rate. Perirenal lymphocele. This is seen in the setting of a transplant. When they are small, you typically just watch them. However, on occasion they get big enough to cause local mass effect on the ureter leading to hydronephrosis. You can totally aspirate them, but they tend to reoccur, and repeated aspiration runs the risk of infecting the collection. For multiple choice, I would say do this, aspirate the fluid and check the creatine. If it's the same as serum, it's probably a lymphocele. If it's more, then it's a urinoma. Either way, you are going to drain them with a catheter. However, if it's a lymphos, you might sclerose the cavity, alcohol, doxy, povidone iodine. Asterisk urinomas that are persistent of any size are drained. 516. Pancreas drainage. Remember that necrotizing pancreatitis is bad, but infected necrotizing pancreatitis is a death sentence. So be careful draining something that is not infected already, otherwise you might make it infected. If you aren't sure if it's infected, consider aspirating some for culture but not placing a tube. Indications. General indications include infected collections or collections causing mass effects, bowel or biliary obstruction. Progression to surgery. If you can get 75% reduction in 10 days, the drain is good enough. If not, the surgeons can use the tract for a video-assisted retroperitoneal debridement, which still avoids open debridement. Pancreatic cutaneous fistula. Other than pancreatic pseudocysts, most pancreatic collections are either brown or grayish. When the fluid is clear, you should think about pancreatic fluid and send a sample for amylase to confirm. If this lasts more than 30 days, then you have yourself a persistent pancreatic fistula. Nice job, idiot. You could have just left it alone. That will teach you to let those medicine docs pressure you into doing stuff that's not indicated. It may be possible to treat that with octreotide, synthetic somatostatin, to inhibit pancreatic fluid, although in these cases extended drainage is usually needed. 517. Section 13, urinary intervention. Percutaneous nephrostomy. Collections are either brown or grayish. Grayish. When the fluid is clear, you should think about pancreatic fluid and send a sample for amylase to confirm. If this lasts more than 30 days, then you have yourself a persistent pancreatic fistula. Nice job, idiot. You could have just left it alone. That will teach you to let those medicine docs pressure you into doing stuff that's not indicated. It may be possible to treat that with octreotide, synthetic somatostatin, to inhibit pancreatic fluid, although in these cases extended drainage is usually needed. 517. Section 13, urinary intervention. Percutaneous nephrostomy, PCN. There are 3 main reasons you might subject someone to this. Relief of urinary obstruction. Urinary diversion. Access for diagnostic and therapeutic procedures. Stones cancer. Urine leak, urine fistula, for pelvic CA or inflammatory process. Whittaker test. Procedures. Stones cancer. Urine leak, urine fistula, for pelvic Ca or inflammatory process. Whitaker test, if it's 1970, access for stone removal, PCNL, dilation or stenting of stricture. PCN contraindications, absolute severe coagulopathy. Technically not possible. INR should be less than 1.5 plt, 50K. Approach would cross colon, spleen, or liver 518. Technical stuff. Prior to the procedure, it would be ideal if you normalize the potassium, dialysis. Certainly anything about 7 should be corrected prior to the procedure. Hold anti-antiplatelet drugs for at least 5 days prior to the procedure. The lower pole of a posteriorly oriented calyx is ideal. The reason you use a posterior lateral, 30 degrees, approach is to attack along Brodel's avascular zone, area between the arterial bifurcation. 30 degrees of sagittal, towards the back. Target should be lateral to the midline, not beyond the posterior axillary line. You don't want to go too medial unless you want to try and dilate through the paraspinal muscles. You don't want to go too lateral or you risk nailing the colon. Choosing a lower target minimizes the chance of pneumothorax. Additional benefit of the posterior calyces approach is that the guide wire takes a less angled approach compared to an anterior calyces approach. Direct stick into the collecting system without passing through renal parenchyma is not a good move, high risk of urine leak. Dilated system equals single stick, ultrasound and stick your ideal target, low and posterior, then use fluoro to wire in, dilate up, and then place the tube. Alternatively, you can do the whole thing under CT. Non-dilated system equals get your partner to do it, these low. If forced to do equals double stick. Ultrasound and stick anything you can. Opacity, phi the system. Then stick a second time under fluoro in an ideal position, low and posterior, then wire in, dilate up, and then place the tube. Alternatively, you can do the whole thing under CT. The posterior calyces, your target, will be seen and on if you use contrast. The anterior ones should be more lateral. If you use air, you should just fill the posterior ones, which will be non-dependent with the patient on their belly. Air is useful to confirm. You place the drain and get frank pus back. Next step equals aspirate the system. G. TETH targeted side. 519. Special situations. Fluorostomy on transplant. The test writer will likely write the question in a way to make you think it's crazy to try one of these. Transplant is not a contraindication. In fact, it's technically easier than a posterior native kidney. Testable transplant trivia. Anterolateral calyx should be targeted instead of posterior. Entry site should be lateral to the transplant to avoid entering the peritoneum. Middle to upper pole instead of a lower pole. Percutaneous inflorestal lithotomy. This is done to remove stones in conjunction with urology. The idea is very similar with a few differences. The most testable difference is that the site is often the upper pole instead of lower pole to make stone access easier. The tube hole is bigger and there's more risk of bleeding. Tube fell out. The trick to handling these scenarios is the freshness of the tube. If the tract is fresh, which USUA11Y means less than a week old, then you have to start all over with a fresh stick. If the tract is mature, which usually means older. Technically not possible. INR should be less than 1.5 plt, 50K. Approach would cross colon, spleen, or liver 518. Technical stuff. Prior to the procedure, it would be ideal if you normalize the potassium, dialysis. Certainly anything about 7 should be corrected prior to the procedure. Hold anti-antiplatelet drugs for at least 5 days prior to the procedure. The lower pole of a posteriorly oriented calyx is ideal. The reason you use a posterior lateral, 30 degrees, approach is to attack along Brodel's avascular zone, area between the arterial bifurcation. 30 degrees of sagittal, towards the back. Target should be lateral to the midline, not beyond the posterior axillary line. You don't want to go too medial unless you want to try and dilate through the paraspinal muscles. You don't want to go too lateral or you risk nailing the colon. Choosing a lower target minimizes the chance of pneumothorax. Additional benefit of the posterior calyces approach is that the guide wire takes a less angled approach compared to an anterior calyces approach. Direct stick into the collecting system without passing through renal parenchyma is not a good move, high risk of urine leak. Dilated system equals single stick, ultrasound and stick your ideal target, low and posterior, then use fluoro to wire in, dilate up, and then place the tube. Alternatively, you can do the whole thing under CT. Non-dilated system equals get your partner to do it, these low. If forced to do equals double stick. Ultrasound and stick anything you can. Opacity, phi the system. Then stick a second time under fluoro in an ideal position, low and posterior, then wire in, dilate up, and then place the tube. Alternatively, you can do the whole thing under CT. The posterior calyces, your target, will be seen and on if you use contrast. The anterior ones should be more lateral. If you use air, you should just fill the posterior ones, which will be non-dependent with the patient on their belly. Air is useful to confirm. You place the drain and get frank pus back. Next step equals aspirate the system. G. TETH targeted side. 519. Special situation. Situations. Fluorostomy on transplant. The test writer will likely write the question in a way to make you think it's crazy to try one of these. Transplant is not a contraindication. In fact, it's technically easier than a posterior native kidney. Testable transplant trivia. Anterolateral calyx should be targeted instead of posterior. Entry site should be lateral to the transplant to avoid entering the peritoneum. Middle to upper pole instead of a lower pole. Percutaneous inflorestal lithotomy. This is done to remove stones in conjunction with urology. The idea is very similar with a few differences. The most testable difference is that the site is often the upper pole instead of lower pole to make stone access easier. The tube eye hole is bigger and there is more risk of bleeding. Tube fell out. The trick to handling these scenarios is the freshness of the tube. If the tract is fresh, which USUA11Y means less than a week old, then you have to start all over with a fresh stick. If the tract is mature, which usually means older than 1 week, you can try and re-access it with a non-traumatic wire. Catheter maintenance. Exchange is required every 2 to 3 months because of the crystallization of urine in the tube. Some hospitals 519. Special situations. Pleurostomy on transplant. The test writer will likely write the question in a way to make you think it's crazy to try one of these. Transplant is not a contraindication. In fact, it's technically easier than a posterior eye native kidney. Testable transplant trivia. Anterolateral calyx should be targeted instead of posterior. Entry site should be lateral to the transplant to avoid entering the peritoneum. Middle to upper pole instead of a lower pole. Percutaneous and pleurostolethotomy. This is done to remove stones in conjunction with urology. The idea is very similar with a few differences. The most testable difference is that the site is often the upper pole instead of lower pole to make stone access easier. The tube eye hole is bigger and there is more risk of bleeding. Tube fell out. The trick to handling these scenarios is the freshness of the tube. If the tract is fresh, which USUA11Y means less than a week old, then you have to start all over with a fresh stick. If the tract is mature, which usually means older than 1 week, you can try and re-access it with a non-traumatic wire. Catheter maintenance. Exchange is required every 2 to 3 months because of the crystallization of urine in the tube. Some hospitals and departments will do exchanges more frequently than 2 months, and that is because of how well this pays. They do it for excellent patient care. Encrusted tube. If this thing gets totally gross, it can be very difficult to exchange in the normal fashion. The most likely next step is to use a hydrophilic wire along the side of the tube, same tract, to maintain access. Ureteral occlusion. Sometimes urology will request that you just kill the ureters altogether. This might be done for fistula, urine leak, or intractable hemorrhagic cystitis. There are a bunch of ways to do it. The most common is probably a sandwich strategy with coils. The sandwich is made by placing large coils or the proximal and distal ends of the nest and small coils in the middle. Big coils equals bread, small coils equals bacon. 520. Nephroureteral stent, news. This urology. The idea is very similar with a few differences. The most testable difference is that the site is often the upper pole instead of lower pole to make stone access easier. The tube eye hole is bigger and there is more risk of bleeding. Tube fell out. The trick to handling these scenarios is the freshness of the tube. If the tract is fresh, which USUA11Y means less than a week old, then you have to start all over with a fresh stick. If the tract is mature, which usually means older than 1 week, you can try and re-access it with a non-traumatic wire. Catheter maintenance. Exchange is required every 2 to 3 months because of the crystallization of urine in the tube. Some hospitals and departments will do exchanges more frequently than 2 months, and that is because of how well this pays. They do it for excellent patient care. Encrusted tube. If this thing gets totally gross, it can be very difficult to exchange in the normal fashion. The most likely next step is to use a hydrophilic wire along the side of the tube, same tract, to maintain access. Ureteral occlusion. Sometimes urology will request that you just kill the ureters altogether. This might be done for fistula, urine leak, or intractable hemorrhagic cystitis. There are a bunch of ways to do it. The most common is probably a sandwich strategy with coils. The sandwich is made by placing large coils or the proximal and distal ends of the nest and small coils in the middle. Big coils equals bread, small coils equals bacon. 520. Nephroureteral stent, news. This is used when the patient needs long-term drainage. It's way better than having a bag of piss strapped to your back. Benign ureter strictures. Malignant ureter obstruction, by far the most common indication. Ureteric injury. Ureteric calculus undergoing lithotripsy. Long-term relief obstruction of urinary news. Technically they can be placed in a retrograde, bladder up, or an antegrade, kidney down fashion. You are going to use the antegrade strategy if A. You've got a nephrostomy tube, or B. Retrograde failed. Can you go straight from nephrostomy to news? Yes, as long as you didn't fuck them up too bad getting access. If they are bleeding everywhere, or they are uroseptic, you should wait. Let them cool down, then bring them back to cover to the news. Who should not get a news? Anyone who doesn't have a bladder that works, outlet obstruction, neurogenic bladder, bladder tumors, etc. It makes no sense to diver the urine into a bladder that can't empty. Bagopis J. PCN. Obstruction. Backslash dash dash dash. Slash. Dash underscore. R dash dash underscore. Slash. Internal news, J. This is the ultimate goal for the patient. The testable stipulation is that this will require the ability to do retrograde exchanges via the bladder. Tile safety, a safety PCN, is often left in place after the deployment of a J PCN. The point is to make sure the stent is going to work. The typical protocol: 1. Place the J and the safety. 2. Cap the safety so that the internal news is draining the patient. 3. Bring the patient back in 24 to 48 hours and squirt the tube, antegrade nephrostogram. The system should be non-obstructed. 4. If it's working, then you pull the safety. 5. If it's not working, you uncap the safety and just leave it as a PCN. Superpubic cystostomy, done to either A. Acutely decompress the bladder, or B. Long-term outflow obstruction, neurogenic bladder, obstructing prostate cancer, urethral destruction, etc. The best way to do it is with ultrasound in the fluoro suite. The target is midline just above the pubic symphysis at the junction of the mid and lower thirds of the anterior bladder wall. You chose this target because the low stick avoids bowel and the peritoneal cavity, the low 1/3 and mid 1/3 junction avoids the trigone, which will cause spasm. The vertical midline is chosen to avoid the inferior epigastric. Use ultrasound and stick it, confirm position with contrast, wire in and then dilate up. Use a small tube for temporary stuff and a larger tube for more long-term stuff. You can always upsize to a Foley once the tract is mature. A 1/6F Foley is ideal for long-term drainage. Contraindications: bunch of pelvic surgeries, extensive scar. Being a big fat pig/cow. Coagulopathy, inability to distend bladder, inability to displace overlying small bowel. 522. Weapon of choice. Let's do a rapid review of urinary diversion options. Obstruction. Scenario 1, dude with a ureteral stricture. ________ J. Obstruction / If you can cross the lesion, and the bladder works, then internal J news is idea. Obstruction. R / -A. Scenario 2. Obstruction. Dude with a ureteral TCC plus a bladder mass. I_A. Obstruction / This guy has obstruction at the ureter and the bladder. The only option is to divert at the level of the kidney. He gets a PCN. Scenario 3, dude with an outflow obstruction, horrible prostate cancer. This guy has obstruction at the bladder. He doesn't need to cross the ureter. He gets a cystostomy. 523. Renal biopsy, this can be done for 2 primary reasons: 1, renal failure, or 2, cancer biopsy. Nonfocal, the renal failure workup, nonfocal biopsy, is typically done with a 14 to 18 gauge cutting needle, with the patient either prone or on their side, target kidney up. The most obvious testable fact is that you want tissue from cortex, lower pole if possible, to maximize the yield of glomeruli on the specimen and minimize complications by avoiding the renal sinus. The complication rate is relatively low, although small AV fistulas and pseudoaneurysms are relatively common, most spontaneously resolve. Some hematuria is expected. In a high risk for bleeding situation, a transjugular approach can be done, but that requires knowing what you are doing. Focal, it used to be thought that focal biopsy should never be done because of the dreaded risk of upstaging the lesion and seeding the tract. This has been shown to be very rare, 0.01%. Having said that, I think it's still the teaching, at least in the setting of pediatric renal masses. This procedure is probably better done with CT. The patient is placed in whatever position is best, but the lateral decubitus with the lesion side down is preferred, as it stabilizes the kidney from respiratory motion and bowel interposition. Just like with ultrasound, not crossing the renal sinus is the way to go. Just put the needle in the tumor. If it's cystic and solid, make sure you hit the solid part. Some texts recommend both fine needle and core biopsy. The core biopsy is going to give a higher yield. A testable pearl is that if lymphoma is thought likely, a dedicated aspirate should be sent for flow cytometry. As with any renal procedure, hematuria is expected, not gross, just a little. Renal colic from blood clots is rare. ACR appropriate ICER practice guide finds, renal biopsy. Renal BX is a procedure with significant bleeding risk, difficult to detect or control. SFR guidelines recommend and holding aspirin for 5 days prior to the procedure. Why 5 days? Aspirin irreversibly inhibits platelet function, and since platelet lifespan is about 7 to 10 days, patients with normal marrow will replenish 30 to 50% of their platelets within 5 days of withholding the willow bark aspirin. 524. Renal RFA, radiofrequency ablation. Ablation, RFA, is an alternative to partial nephrectomy and laparoscopic nephrectomy. It can be used for benign tumors like AMLs, renal AVMs, and even for RCCs, angiomyolipomas. AMLs are treated at 4 centimeters because of the bleeding risk. Sort of a general rule is that things that are superficial you can burn with RFA. Things that are closer to the collecting system it may be better to freeze, cryoablation, to avoid scaring the collecting system and making a stricture. Pyeloperfusion techniques, cold D5W irrigating the ureter, can be done to protect it if you really wanted to RFA. If anyone would ask, RFA has no effect on GFR, it won't lower the GFR. Things that make you think recurrent/residual disease after therapy: 1. Any increase in the size beyond the acute initial increase. 2. Areas of nodular or crescentic enhancement. Or 3. A new or enlarging bright T2 signal. There is a paper in AJR 2009 that says that lesions that are 3 cm will appear larger in 1 to 2 months and lesions 3 cm do not grow larger when successfully treated. So smaller lesions may initially get bigger, but after that any increase in size should be considered tumor recurrence. Renal arteriography. You should always do a non-selective aortogram first to see how many arteries feed the kidney, where they are, etc. Sometimes the aortogram will show you an obvious osteal problem which you can then select down on an address. Otherwise, you need to do selective angiography and look at each vessel. LAO is the projection of choice for looking at the renals. Sometimes the stenosis is further out. In fact, branch artery stenosis is a cause of hypertension in kids. Angioplasty of renal arteries, used to treat hypertension caused by atherosclerosis, usually osteal, or FMD. Risks include thrombosis and vessel spasm. Calcium channel blockers can be given to decrease the risk of spasm. Heparin should be on board to reduce thrombosis risk. Most people take daily aspirin the day before and every day after for 6 months to reduce the risk of restenosis. Indications for angioplasty equals renal vascular HTN, or azotemia atherosclerosis, at the ostium equals angioplasty plus stent FMD, usually mid-vessel equals angioplasty alone. 525. Renal hemorrhage. Trauma to the kidney, usually iatrogenic from biopsy or diversion procedure, can typically be embolized. The renal arteries are end arteries, which means that collaterals are not an issue. It also means that infarction is a legit issue, so if you want to salvage the kidney you need to try and get super selective. Having said that, don't be an idiot and fuck around trying to get super selective while the patient is bleeding to death. Remember, most people have 2 of these things, plus in a worst case scenario there is always dialysis. Bottom line, if you get into trouble and the patient is crashing, just trash the whole thing. Next step, arterial trauma from the nephrostomy tube placement. Bleeding source is occult on angio. Next step. Remove the nephrostomy, over a guide wire, then look again. Often the catheter tamponades the bleed, making it tougher to see. Gamesmanship. Oral boards guys used to be sticklers for the phrase, over a wire. In other words, if you just said, I'd remove the PCN, they would ding you. You have to say, I'd remove the PCN over a wire. The only reason I bring this up is the use of possible distractors I fuckery. Maybe something like this. Q. The highly skilled interventionalist grants the fellow the great privilege of performing a fresh stick nephrostomy. The clumsy good-for-nothing fellow manages to place the tube, but now there is a large volume of bright red blood in the tube, and the patient's blood pressure is dropping rapidly. You start fluids and perform an emergent renal arteriography. The source of bleeding is not seen. What is the best next step? A. Remove the PCN and repeat another angio run. B. Kick the fellow in the shin for using too much fluoro time, just like a midget using. C. Call urology and admit you need help from a real doctor. A orinal. Yo, you go TTAD. Remove the PCN over a wire and repeat another angio run. ___________ stay on your TOES. S. Read all the choices. Renal aneurysms. Look, man. I only need to know one thing, where they are. Private Vasquez. Small segmental arteries equals coils. Main renal artery equals covered stent to exclude the aneurysm. Alternatively, you could place a bare metal stent across the aneurysm, and then pump detachable coils into the sac. 526. Section 14, Pulmonary Intervention. Pleural drainage. Most everyone has done a few thoracentesis as a resident. I just want to touch on a few testable points. Remember that you go above the rib to avoid the neurovascular bundle. If you pull off too much fluid too fast, you can possibly get pulmonary edema from re-expansion. This is uncommon. If it's malignant, you might end up with a trapped lung. Lung won't expand fully. A vacothorax in the setting of a trapped lung does not mean anything and does not need immediate treatment even if it's big. If you really need to fix it, you'll need a surgical pleurectomy id decortication. Pleurodesis, which can be done to patients with recurrent pleural effusions, does not help in the setting of trapped lung. Pneumothorax is rare but is probably the most common complication. Obviously it's more common when done blind. Additional trivia related to chest tubes. Continuous air bubbles in the pleurivac chamber represent an air leak, either from the drainage tubing or from the lung itself. In the setting of multiple choice, think about a bronchopleural fistula. INR should generally be 1.5 prior to placement of a chest tube. In the paravertebral region, the intercostal vessels tend to course off of the ribs, and are therefore more prone to injury if this route is chosen for chest tube placement. Lung abscess. Just remember that you can drain an empyema, pus in the pleural space, but you should not drain a lung abscess because you can create a bronchopleural fistula. Some people still do it. 527. Lung biopsy. The most common complication is pneumothorax, which occurs about 25% of the time. Most either resolve spontaneously or can be aspirated, with about 5% needing a chest tube. The second most common complication, usually self-limiting, is hemoptysis. The testable pearls include: the lower lung zones are more affected by respiratory motion. The lingula is the most affected by cardiac motion. Avoid vessels greater than 5 mm. Try and avoid crossing a fissure, they almost always get a pneumothorax. Areas lateral to and just distal to the tip of a biopsy gun will be affected by shockwave injury, so realize vessels can still bleed from that. Reducing the risk of pneumothorax post-biopsy. Enter the lung at 90 degrees to pleural surface. Avoid interlobar fissures. Put the patient puncture side down after the procedure. No talking or deep breathing after the procedure, at least 2 hours. If the patient is a cougher, consider postponing the procedure, or giving empiric antitussive meds. When to place a chest tube. Post-biopsy. Pneumothorax is symptomatic. Pneumothorax continues to enlarge on serial radiographs. Pneumothorax chest tubes often I0 French pigtail catheters which require 180 needle I0.035 amp Latz wire. Lung RFA, radiofrequency ablation of lung tumors can be performed on lesions between L.5 cm and 5.2 cm in diameter. The most common complication is pneumothorax. More rare things like pneumonia, pseudoaneurysm, bronchopleural fistula, and nerve injury have been reported. The effectiveness of RFA is similar to external beam radiation with regard to primary lung cancer. The major advantage of lung RFA is that it has a limited effect on pulmonary function and can be performed without concern to prior therapy. Imaging, CT and PET, should be performed as a follow-up of therapy. Things that make you think residual/recurrent disease: nodular peripheral enhancement measuring more than 10 mm, central enhancement, any is bad, growth of the RFA zone after 3 months, after 6 months is considered definite, increased metabolic activity after 2 months, residual activity centrally, at the burn tumor. 528. Thoracic Angio. This section is going to focus on the 2 main flavors of pulmonary angio: pulmonary artery, done for massive PE, and pulmonary AVM treatment, and bronchial artery, done for hemoptysis. Pulmonary artery. The primary indications for PU1 monary arteriography is diagnosis and treatment of massive PE or pulmonary AVM. Technical trivia. The Grolman catheter, which is a Pres Hape 7F, is the classic tool. You get it in the right ventricle, usually from the femoral, and then turn it 180 degrees so the pigtail is pointing up, then advance it into the outflow tract. Some people will say that a known LBBB is high risk, and these patients should get prophylactic pacing because the wire can give you a RBBB, and RBBB plus LBBB equals acysto 1E. An important thing to know is that patients with chronic PE often have pulmonary hypertension. Severe pulmonary hypertension needs to be evaluated before you inject a bunch of contrast. Pressures should always be measured before injecting contrast because you may want to reduce your contrast burden. Oh, one last thing about angio: never ever let someone talk you into injecting contrast through a Swan-Ganz catheter. It's a terrible idea, and the stupid catheter will blow apart at the hub. I would never ever do that. Next step, cardiac dysrhythmias, VTACH during procedure. Next step, reposition the catheter I wire. Pulmonary embolism, patients with PE should be treated with medical therapy, anticoagulation with Coumadin, heparin, or various newer agents, allowing the emboli to spontaneously undergo lysis. In patients who can't get anticoagulation, for whatever reason, IVC filter should be placed. The use of transcatheter therapy is typically reserved for unstable patients with massive PE. Massive PE. Just think lot of PE with hypotension. In those situations, catheter-directed thrombolysis, thromboaspiration, mechanical C1OT fragmentation, and stent placement have all been used to address large clots. Pulmonary angiography relative contraindications. Pulmonary HTN with elevated right heart pressures, greater than 70 systolic and 20 end diastolic. If you need to proceed anyway, they get low osmolar contrast agents injected in the right or left paw, not the main paw. Left bundle branch block, the catheter in the right heart can cause a right block, leading to a total block. If you need to proceed anyway, they get prophylactic pacing. 529. Pulmonary AVM, they can occur sporadically. For the purpose of multiple choice, when you see them, think about HHT, hereditary hemorrhagic telangiectasia, I. Osler-Weber-Rondeau. Pulmonary AVMs are most commonly found in the lower lobes, more blood flow, and can be a source of right to left shunt, worry about stroke, and brain abscess. The rule of treating once the afferent vessel is 3 mm is based on some tiny little abstract and not powered at all. Having said that, it's quoted all the time, and a frequent source of trivia that is easily tested. The primary technical goal is to crush the feeding artery, usually with coils, as close to the sac as possible. You don't want that think reperfusing from adjacent branches. Pleurisy, self-limited, after treatment seems to pretty much always happen. Key trivia: HHT association brain abscess I stroke, via paradoxical emboli treat once the afferent vessel is 3 mm. Coils in the feeding vessel, as close as possible to the sac. Special situation, Rasmussen aneurysm. This is an aneurysm associated with chronic pulmonary infection, classically TB. The trick on this is the history of hemoptysis, which normally makes you think bronchial artery. It's a trap. Admiral Joel Akbar. Next step, strategy to avoid the trap, patient blah 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 hemoptysis. Next step. Bronchial artery angio is negative, still bleeding. Oh, and his PPD is positive. Next step. Pulmonary artery angio to look for Rasmussen aneurysms. Rasmussen aneurysm identified. Next step. Coil embolization, yes, coils for hemoptysis, this is the exception to the rule. 530. Bronchial artery. The primary indications for pulmonary arteriography is diagnosis and treatment of massive hemoptysis. Hemoptysis, massive hemoptysis, 300 cm cubed, can equal death. Bronchial artery embolization is first-line treatment. Bronchial artery is the culprit 90% of the time. Unique to the lung, active extravasation is not typically seen with the active bleed. Instead you see tortuous, enlarged bronchial arteries. The main thing to worry about is cord infarct. For multiple choice, the most likely bad actor is the hairpin-shaped anterior medullary artery. Embolizing that thing or anywhere that can reflux into that thing is an obvious contraindication. If present, those bad boys typically arise from the right intercostal bronchial trunk. Particles 325 micrometers are used. Coils should be avoided because if it rebleeds you just jailed yourself out. The vast majority, 90%, of bronchial arteries are located within the licency formed by the left main bronchus. This is right around the T5, T6 level. There is a ton of vascular variation, but the pattern of an intercostobronchial trunk on the right and two bronchial arteries on the left is most common, about 40%. Hairpin turn of the anterior medullary artery. Li. 531. Occlusion of central veins, SVC syndrome. Yes, I know this really isn't a pulmonary thing, but it is in the chest, so I'm going to talk about it here. Acute SVC occlusion equals emergency. Chronic SVC occlusion is not, has collaterals. There are a variety of ways to address occlusion of the SVC. The goal is to return in line flow from at least one jugular vein, down through the SVC. Most commonly thrombolysis is the initial step, although this is rarely definitive. The offending agent, often a catheter, should be removed if possible. If the process is non-malignant, often angioplasty alone is enough to get the job done post-lysis. Technical trivia: malignant causes, you should do lysis, then angioplasty, then stent. Non-malignant causes may still need a stent if the angioplasty doesn't remove the gradient, if the collateral veins are still present. Self-expanding stents should not be used, as they tend to migrate. The last pearl on this one is not to forget that the pericardium extends to the bottom part of the SVC, and that if you tear that you are going to end up with hemopericardium and possible tamponade. 532. Section 15. Reproductive intervention. Uterine artery embolization, UAE. This has been around a long time, and can be used for bleeding or the bulk symptoms of fibroids. Patient selection: not all fibroids were created equal. Submucosal does the best. Intramural does the second best. Serosal does the third best. It sucks. Smaller lesions do better than larger lesions. Cellular fibroids, which are densely packed smooth muscle, without much connective tissue, and high T2 signal tend to respond well to embolization. Intracavitary fibroids, less than 3 centimeters. Next step equals GYN referral for hysteroscopic resection. Intracavitary fibroids, less than 3 centimeters, with failed hysteroscopic resection equals IR embo. Large serosal fibroid, patient wants to be pregnant, no history of prior myomectomy equals GYN referral for myomectomy. Pedunculated serosal fibroid equals GYN referral for resection. Broad ligament fibroid equals refer to voodoo priest. These don't do well with UAE, and are technically challenging to operate on. Pre-treatment considerations. Trivia. Remember, fibroids are hormonal responsive. They grow with estrogen, and really grow during pregnancy. Gonadotropin-releasing medications are often prescribed to control fibroids by blocking all that fancy hormone axis stuff. The testable trivia is to delay embolization for 3 months if someone is on the drugs, because they actually shrink the uterine arteries, which makes them a pain in the ass to catheterize. The EMI trial showed that hospital stays with UAE are shorter than hysterectomy. The incidence of premature menopause is around 5%. DVT, IP, is a known risk of the procedure. Once pelvic vein compression from large fibroid releases, sometimes the big PE flies up. The risk is about 5%. Contraindications: pregnancy, uterine/cervical cancer, active pelvic infection, prior pelvic radiation, connective tissue disease, prior surgery with adhesions, relative. 533. Treatment trivia. Remember, the uterine artery is off the anterior division of the internal iliac regardless of the fibroid location. Bilateral uterine artery embolization is necessary to prevent recruitment of new vessels. In most cases, branches of the ovarian artery feed the fibroids via collaterals, with the main uterine artery occlusion of small small feeding arteries cause fibroid infarction, and hopefully shrinkage. Embolic material is typically PVA, or embospheres for fibroids, targeting the pre-capillary level. For postpartum hemorrhage, vaginal bleeding gel foam, or glue is typically used. Treatment of adenomyosis with UAE is done exactly the same way, and is an effective treatment for symptomatic relief, although symptoms recur in about 50% of the cases around 2 years post-treatment. Fibroids should reduce volume 40 to 60% after the procedure. Post-Embolization Syndrome. I mentioned this earlier, but just wanted to remind you that it's classically described with fibroid embolization. Remember, you don't need to order blood cultures, without other factors to make you consider infection. The low-grade fever should go away after 3 days. Some texts suggest prophylactic use of antipyrexial and antiemetic meds prior to the procedure. 3 days or less with low-grade fever equals do nothing. More than 3 days with fever equals work it up, cultures, antibiotics, etc. Hysterosalpingogram, DSG, I'm 100% certain no one went into radiology to do these things. You do it like a GYN exam. Prep the personal area with betadine, drape the patient, put the speculum in and find the cervix. There are various methods and tools for cannulating and maintaining cannulation of the cervix, vacuum cups, tenoculums, balloons. Insertion of any of these devices is made easier with a catheter and wire. Once the cervix and endometrial cavity have been accessed, the contrast is inserted and pictures are obtained. Contraindications: pregnancy, active pelvic infection, recent uterine or tubal pregnancy. Trivia. The ideal time for the procedure is the proliferative phase, day 6 to 12, as this is the time the endometrium is thinnest, improves visualization, minimizes pregnancy risk. It's not uncommon for a previously closed tube to be open on repeat exam. Sedative, narcotics, tubal spasm can make a false positive. Air bubbles can cause a false positive filling defect. Intravasation, the backflow of injected contrast into the venous or lymphatic system, used to be an issue during the Jurassic period, when oil-based contrast could cause a fat embolus. Now it means nothing other than you may be injecting too hard, or the intrauterine pressure is increased because of obstruction. The reported risk of peritonitis is 1%. Fallopian tube recanalization, FTR. Tubal factors, usually PID, chlamydia, are responsible for about 30% of the cases in female infertility depending on what part of the country you are from, sometimes much more. Insert joke about your hometown here. Tubal obstruction comes in two flavors, proximal, interstitial, or distal. The distal ones get treated with surgery. The proximal ones can be treated with an endoscope, or by poking it with a wire under fluoro. Things to know: you should schedule it in the follicular/proliferative phase, thus like a HSB, day 6-12-ish. You repeat the HSG first to confirm the tube is still clogged. If clogged, you try and unclog it with a wire, selective salpingography. Hydrophilic 0.035 or 0.018 guide wire, plus I- microcatheter, is the typical poking tool. Repeat the HSG when you are done to prove you did something. Contraindications are the same as HSG, active infection and pregnancy. 535. Pelvic congestion syndrome, women have mystery pelvic pain. This is a real, maybe, cause of it. They blame dilated ovarian and periuterine veins in this case, and give it a name ending in the word syndrome to make it sound legit. The symptoms of this syndrome include pelvic pain, dyspareunia, menstrual abnormalities, vulvar varices, and lower extremity varicose veins. The symptoms are most severe at the end of the day and with standing. Diagnosis. Clinical symptoms and a gonadal vein diameter of IOM, normal, is 5 mm. Treatment. GnRH agonists sometimes help these patients, since estrogen is a vasodilator. But the best results for treatment of this syndrome are sclerosing the parauterine venous plexus and coil/plugs in the ovarian and internal iliac veins, performed by your local interventional radiologist. This is often staged, starting with ovarian veins plugged first, and then, if unsuccessful, iliac veins are plugged second. Trivia: most optimal results occur when the entire length of both gonadal veins are embolized. Complications. Complications are rare, but the one you worry about is thrombosis of the parent vein, iliac or renal, and possible thrombus migration, pulmonary embolism. Will it get better on its own? The symptoms will classically improve after menopause. 536. Varicocele, they are usually left-sided, 90%, or bilateral, 10%. Isolated right-sided varicoceles should prompt an evaluation for cancer. Next step equals CT-ABD. When do you treat them? There are 3 indications: 1. Infertility, 2. Testicular atrophy in a kid, 3. Pain. Anatomy trivia: regarding varicoceles, remember that multiple venous collaterals, pampiniform plexus, or spermatic venous plexus, drain the testicles. Those things come together around the level of the femoral head, forming the internal spermatic vein. The left internal spermatic vein drains into the left renal vein, and the right internal spermatic vein drains into the IVC. Common variants include multiple veins on the right terminating into the IVC, or renal vein, or one right-sided vein draining into the renal vein, instead of the IVC. Why varicoceles happen: the primary factor is right angle entry of the left spermatic vein into the high-pressure left renal vein. Nutcracker syndrome, compression of the left renal vein between the SMA and aorta on the left, is another cause, probably more likely asked. Basic idea: you get into the renal vein and look for reflux into the gonadal vein, internal spermatic, which is abnormal but confirms the problem. You then get deep into the vein and embolize close to the varicocele, often with foam, then drop coils on the way back, and often an Amplotzer or other occlusion device at the origin. 537. SEC 110N16, miscellaneous topics. Vertebroplasty. There is a paper in the NEJM that says this doesn't work. Having said that, NEJM doesn't like any procedures. They're run by family medicine doctors. They are equally amoral to the person that will do any non-indicated procedure. Regardless of the actual legitimacy, it's a big cash cow, and several prominent radiologists have made their names on it. So it will be tested on as if it's totally legit, and without controversy. Trivia to know. Indications equals acute to subacute fracture with pain refractory to medical therapy, or an unstable fracture with associated risk if further collapse occurs. Contraindications equals fractures with associated spinal canal compression, or improving pain without augmentation. There is a risk of developing a new vertebral fracture in about 25% of cases. The literature says you should counsel patients on the need for additional treatments prior to undergoing vertebroplasty. The cement can embolize to the lungs. Risk of local neurologic complications are about 5%. Lymphangiogram. 1950 called and they want to stage this cancer. Prior to CT, MRI, and US injecting dye into the toes was actually a way to help stage malignancy, mets to lymph nodes, lymphoma, etc. Another slightly more modern application is to use this process as the first step in the embolization of the thoracic duct. Why would you take down the thoracic duct? Fits leaking chylus pleural effusions, status post get hacked to pieces by a good-for-nothing surgery resident. Technical trivia. This is done by first injecting about 0.5 centimeters cubed in between the toes bilaterally. You then wait a half an hour until the blue lymphatic channels are visualized. You then cut down over the lymphatic channels and cannulate with a 27 or 30 gauge lymphangiography needle. An injection with hepiodol is done, maximum 20 milliliters if no leak. If you inject too much there is a risk of oil pneumonitis. You take spot films in a serial fashion until the cisterna chyli, the sac at the bottom of the thoracic duct, is opacified. At that point you could puncture it directly and superselect the thoracic duct to embolize it, typically with coils. 538. Standing waves. Standing waves are an angiographic phenomenon, usually, that results in a ringed layering of contrast that sorta looks like FMD. A common trick is to try and make you pick between FMD and standing waves. Obviously it's bullshit because in real life standing waves typically resolve prior to a second run through the same vessel, and even if they stayed around they tend to shift position between each run, up or down. FMD on the other hand is an actual physical irregularity of the vessel wall so it's fixed between runs and doesn't go away. Morphology should be your strategy for multiple choice. Standing waves are very symmetric and evenly spaced. FMD is more irregular and asymmetric. The lingo. Standing waves FMD. Give me a IO x6 balloon, this means a iom diameter x 6 cm length balloon. Give me 20 J, JR30, this means do an angio run at 20 cc/SEC for a total of 30 seconds. Squirted an angiogram, oh really? A Sputnik lac with active extrav. Let's call IR right away and get him squirted. Thrash, a difficult case, hot mess, I have an admit for you. This lady is a hot mess. That poor lady, a way of feigning sympathy. Sick as stink also, sick and stinks, be careful not to mess this up. 539. Artery of interest see arm angulation miscellaneous. Aortic arch 70 degrees Lao candy cane. Innominate, right subclavian row in the Lao the right and right common carotid, subclavian and right common carotid overlap. Left subclavian Lao. Mesenteric vessels lateral to steep row. Left renal Lao same side as renal. Right renal row or Lao, this is controversial, depending on who lot of sources will say you ask. You can get away with Lao. Left iliac bifurcation row opposite side common. Right iliac bifurcation Lao opposite side common. Left common femoral bifurcation Lao isolateral oblique. Right common femoral bifurcation row ipsilateral oblique. The confusing oblique views. Normally, views are defined by the direction of the X-ray beam. However, in angio it gets a little squirrely. The sidedness refers to the side of the eye. Row, the imaging intensifier, is on the right side of the patient. A reasonable person might call this LPO, but they would be wrong. Lao, the imaging intensifier, is on the left side of the patient. A reasonable person might call this RPO, but they would be wrong. Superficial or deep. Understanding geometry. Sometimes it's difficult to tell if you are superficial or deep to the lesion you are trying to put a needle in under furoro. You can problem solve by tilting the eye towards the patient's head or towards the patient's feet. If you tilt towards the head, a superficial needle will be shorter but a deep needle will look longer. If you tilt towards the feet, a superficial needle will be longer but a deep needle will look shorter. Arrow equals needle image receptor. I tilted towards patient's head, superficial needle looks shorter, a deep needle looks longer. 8 plus dash dash I tilted towards 8. Patient's feet, I is superficial needle. Plus dash dash I looks longer, a deep needle looks shorter. I. Medications. Anticoagulation issues. Remember that platelets replace platelets. Cryoprecipitate is used to correct deficiencies of fibrinogen. Heparin, the half-life is around 1.5 hours. Protamine sulfate can be used as a more rapid heparin antidote. Protamine can cause a sudden fall in BP, bradycardia and flushing Coumadin. Vitamin K can be given for Coumadin, but that takes a while, 25 to 50 milligrams, JM for hours prior to procedure. More rapid reversal is done with factors cryoprecipitate. Remember that patients with HIT, heparin-induced thrombocytopenia, are at increased risk of clotting, not bleeding. If they need to be anticoagulated then they should get a thrombin inhibitor instead. Remember those end in Rudin and Gatran. The half-life of a platelet is 8 to 12 days for desmopressin can increase factor 8, may be helpful of hemophilia. Medication mechanism trivia. Inhibits thromboxane AZ irreversible, works the life aspirin from arachidonic acid buy-in of the platelet, 8 to 12 days. Irreversible acetylation. binds antithrombin 3, and monitored by PTT. Can be heparin increases its activity. Reversed with protamine sulfate. Inhibits the binding of ADP Plavix, clopidogrel, to its receptors, leads to inhibition of GP ILFLA. Inhibits vitamin K monitored by INR. Delay-dependent factors, 2,7,9,10, in onset of activity, 8 to 12 hours. Action can be coumadin antagonized by vitamin K, but this takes time, 4 hours. For immediate reversal give factors, cryoprecipitate. Thrombolytic agents act directly or indirectly to TPA, has a very short convert plasminogen to biologic half-life, between TPA, plasmin, cleaves fibrin, 2 to 10 minutes. 542. ACR appropriate, ICER practice guide, pre-procedure hold. For procedures with a moderate risk of bleeding, liver or lung biopsy, abscess drain placement, vertebral augmentation, tunneled central line placement. LNR be corrected to 1.5 prior to the procedure. Aspirin need not be held, clopidogrel, Plavix, should be held for 5 days. Platelet count should be more than 50,000. Sedation related. Conscious sedation is considered moderate sedation, and the patient should be able to respond briskly to stimuli, verbal commands, or light touch. No airway intervention should be needed. Flumazenil is the antidote for versed, midazolam. Narcan is the antidote for opioids, morphine, fentanyl 1. Local anesthesia, lidocaine. Maximum doses for -5 mg/kg. Remember that small doses in the right spot can cause a serious reaction. 150 mg in the thecal sac can cause total spine anesthesia, and the need for a ventilator. Direct arterial injection can cause immediate seizures. Tinnitus and dizziness are the earliest signs of toxicity. Local anesthesia agents have a low potential for allergy, although it can still occur. It's usually a bogus allergy once a real history is taken. Most allergies to lidocaine are actually vasovagal, or other CV side effects from epinephrine mixed with lidocaine. There are elaborate mechanisms for testing for a true allergy, or reaction to methylparaben, a preservative. So what if the allergy is real? Or you can't prove it's false? False. Some texts describe using an antihistamine such as diphenhydramine, which can have anesthetic properties. Green, Stephen M., Stephen G., Roth. Indications. Contraindications. Angiography numerous, usually only one absolute, which is in diagnosis of and treatment unstable patient with multisystem vascular disease dysfunction, unless angio is life-saving. There are numerous relatives including inability to lay flat, uncooperative patient, and connective tissue diseases. Ascending diagnosis of DVT, venography evaluate venous malformation or tumor encasement. Contrast reaction. Descending evaluation of post-pregnancy venography thrombotic syndrome, valvular incompetence. Incompetence and severely compromised damage following DVT cardiopulmonary status. Venography, non-thoracic outlet inclusive. Syndrome, venous access, pacer placement, eval for fistula. IVC filter can't get anticoagulation, total thrombosis of IVC failed anticoagulation, clot progression, IVC too big or too small massive PE requiring lysis, chronic PE treated * sepsis. Sepsis is not a contraindication, with including septic thrombophlebitis thromboendarterectomy. Trauma high risk DVT. Fistulography making the nephrologist absolute, right to left money, slow flows, they cardiopulmonary shunt, uncorrectable call it. Coagulopathy, fistula infection. Relative is significant cardiopulmonary disease, a declot invariably causes PE. Performed prior to absolute, uncorrectable transhepatic percutaneous biliary coagulopathy, Plavix or other anticholangiography interventions, platelet agent, PTC, Caladity Syndrome patients, liver transplant, relative, large volume ascites with suspected obstruction, consider PARA, and left-sided approach. Percutaneous biliary basically CBD, no absolute contraindications drainage obstruction, with failed ERCP, cholangitis, bile relative, large volume ascites duct injury/leak. Consider PARA and left-sided approach, coagulopathy. Percutaneous cholecystitis in patients no absolute contraindications cholecystostomy, who are not surgical candidates, unexplained relative, large volume ascites sepsis when other sources, consider PARA, and left-sided excluded, access to approach, coagulopathy biliary tree required and other methods failed. Percutaneous obstructive uropathy uncorrectable coagulopathy, contrast nephrostomy, not hydronephrosis, reactions urinary diversion, leak, fistula, access for percutaneous intervention. 545. Blank for notes. 546. Blank for notes. 547. Blank for notes. Rise and grind. 550.